Thank you for the very kind invitation. I am Mohammed Imam, a consultant upper limb surgeon in Southwest London and the medical director and professor at the Smart Health Center in London. It's a pleasure to talk to you about suprascapular nerve entrapment. Basically, we haven't evolved as humans as much as we think we are. And unfortunately, our demands has significantly increased over the last few decades. And that's why we're starting to see more of different problems, especially in shoulders. And it is important to understand the suprascapular nerve anatomy in order to be able to treat these problems. There are motor, sensory, and cutaneous branches of the nerve, and those patients will have shoulder pain, weakness caused by suprascapular nerve palsy, either from attraction or compression. First report of this problem was in 1959, and it was up to 1982 when we started to understand that there are two specific locations for entrapment of this nerve. It is important to understand the anatomy of the suprascapular nerve. It comes from the superior trunk of the brachial plexus, and these are the common sites for entrapment. First site is the compression of the nerve with the transverse scapular ligament, and the second place is the spinoglenoid ligament. And we've done cadaveric dissection, and looking at this nicely colored version, you can see that the nerve is very close to the glenoid. That's why it's commonly injured if you are in shoulder replacement. If you put long screws, especially the top ones, we start to see these patients with fracture dislocations and traumatic injuries. So it is important to understand the anatomy. The superior transverse scapular ligament is a common site for compression of the nerve, and if the nerve is entrapped here, it will affect both supraspinatus and infraspinatus, but if it is entrapped only at the spinoglenoid, it will affect the infraspinatus tendon alone. We see bimodal presentation here in younger overhead athletes, possibly because of SGL hypertrophy in patients with GERD problem. You will find the nerve, and usually it affects the infraspinatus tendon alone. In elderly patients with calf tears, that's a common presentation for those with suprascapular nerve palsy. Those as well, as this has been reported after slab repair and lateral J's as well as replacements. It is common in trauma, and we found that EMG has had abnormal findings in almost 1/3 of patients with proximal humeral fracture dislocations. So, as I said, we didn't know about it till 1959. From 1959 to 2001, only 88 reported cases. Biggest study was in 2011. 53 patients, and they have bimodal distribution. If in younger athletes, it's usually at the spinoglenoid notch or usually isolated infraspinatus. In elderly patients with supraspinatus tendon tears, they might have a suprascapular notch entrapment. And these are the two commonest sites. Okay, so first question, when you see these patients, is there a cyst or not? In patients with no cyst, the majority will recover, and that's why we are lucky missing these diagnoses in some of our patients, and they do well. In those with cysts, it's less likely to recover, and surgery might be indicated. Those patients can come with frank wasting of the infraspinatus tendon, as you can see here. And for all of them, I do an MRI scan to diagnose the presence of a cyst. I do an EMG, which can be technically challenging. So I have a neurologist who is experienced in doing this. And EMG will have steep positive sharp waves fibrillation and spontaneous activity. And you cannot actually EMG will be negative in a good portion of these patients, especially if done below 3 weeks from onset of symptoms. So I usually wait for 3 to 6 weeks, before undertaking these studies. If there is no cyst, I'll still manage them non-operatively. If there is a cyst, we have different options ranging from aspiration using ultrasound guided to decompression, either done arthroscopic or open. And with the open approach, you can do a deltoid splitting approach, or you can go from the top with either a direct skin incision over the superior transverse ligament, which is the trapezius splitting approach, or in case of masses or lesions, you can go with extensile approach where you elevate the trapezius. My so obviously in the right hands, you can undertake an ultrasound guided aspiration, which can be successful here. If not, arthroscopy is my preferred option. You have to identify the CA ligament, identify the coracoid and the CC ligaments, follow the coracoid medially into the notch, create a superior portal, retract the supraspinatus with a probe, identify the vessel and the nerve, and then cut the ligament. So Gerber and Warner published 2 different routes to the nerve. In the case of slap tear, you can go through the glenohumeral joint. In cases of no cyst and no obvious site of compression, and you want to release the ligament, I think the Purcell route is easier to go there. In the case of cyst, there is 2 schools of thoughts. You can either drain the cyst and repair the slap tear, or just go and repair the slap tear, and we'll discuss the results of these. So in case of Purcell route, what I tend to do after finishing my glenohumeral arthroscopy, any concomitant pathology is addressed. Then, as you can see, in the subacromial space is then evaluated, and persectomy is undertaken. I find the coracoacromial ligament. Then from the posterior and lateral portal, the ligament is the lighthouse to the coracoid and the landmark to approach the nerve. The section is then carefully undertaken between the CA ligament and the anterior portal of the supraspinatus tendon. This plane is followed to the base of the coracoid and the coracoclavicular ligament using blunt dissection medially. Now an Vizier portal is created, the superior portal, and the blunt trocar is introduced to aid blunt dissection at the level of the suprascapular notch. You can see the nerve here on the left with the ligament on the top of the top right of the screen and the coracoid on the right side. Blunt dissector is applied, and the callison is then introduced to release the ligament. A notchoplasty then can be undertaken, and after doing your notchoplasty, you keep the vessel and the nerve on the left aspect, and here you can see the vessel which is intact. Some of these patients are difficult to diagnose. They have chronic posterior pain, normal EMG and MRI, and then this would be a diagnosis by exclusion. This is the algorithm of managing these patients, and it is crucial to understand all the relevant aspects here. Finally, in those in younger population, you have to ask yourself what to do for them, and then check if there is a cyst or not. And based on evidence, you can do just lab repair. And if there is no compression and no compressive lesion, try conservative treatment, which is successful most of the time. Just doing a slab repair has been successful in 80% of the time, as per this paper published by Yomital. If you have cuff tears, it's all about the angle of the cuff, because normally it should be 142 degrees. In massive tears, it is 35 degrees. And Appleton published their studies that they found 2 to 3 centimeter retraction of all motor branches. Warner and Gerber published a paper on traction injuries if there is a retraction of more than 3 centimeter. Kostoras, a surgeon in Stanford, in his fellowship with J.P. Warner in Harvard, they found that after repairing these tears, the nerve achieved full recovery. Obviously, if it doesn't, you can consider decompression, and an elderly patient with irreparable tears, suprascapular nerve palsy is a good option. Finally, know where is the entrapment site, get EMG and MRI. It is a clinical diagnosis. If there is no cyst, non-operative treatment. If there is a cyst, consider surgery. If you're going to do surgery, do it on cadavers first. If you have an overhead athlete and there is a space-occupying lesion with wasting and EMG changes, they will do well with surgery. If not, posterior capsular program is as effective as surgery, if no compression lesion. If you have someone with neuropathy without a tear and without compression, conservative treatment. If it fails, consider decompression, adds a superior transverse scapular ligament. In case of passive retracted tears, repair can work if it doesn't decompress. If it doesn't, or in case of irreparable tears, or the patient is not fit for surgery, suprascapular nerve ablation would be my treatment of choice. Finally, we still not wiser, but we understand more about it now. Thank you very much for having me today. I'm happy to take any questions by email. Thank you.